We go live to Bangalore.
Greetings from Jaya Deva Institute of Cardiology. Okay. Yeah. Yes, Bharat?
No,
Yeah,
it's Suresh Kumar.
I
Good
think you
afternoon,
can
Suresh.
start.
I am Dr. Srinivas and this is Dr. Jairangnath. All of you know.
Yes, Srinivas?
Yeah.
Okay. First slide.
Yeah. You are presenting your case.
Yeah, I am Srinivas.
Please go ahead.
Yeah, we'll just present the case.
We'll present a case. It's a 35-year-old female, class 2 dyspnea, increased for last 2 weeks. One uneventful pregnancy. It's a normal delivery. Next slide. Undernourished, weighing only 30 kilo, hyperdynamic precardium, short systolic murmur. Saturation both upper and lower limb is 97%. This is the ECG, which clearly shows there is still a lot of left ventricular forces, biventricular overload. X-ray shows cardiomegaly with a plethoric lung fields, dilated PA. This is the echocardiogram. You can see mildly dilated left atrium and left ventricle. Compared to the right atrial ventricle, left side the chambers are enlarged. The trivial mitral regurgitation. Next slide. This is the dilated PA. This is the ductal view. You can see a large duct, a fairly big ampulla. It's a bidirectional shunt, predominantly left to right, predominantly left to right. Next. Next. You could see that ampulla is measuring around 20 millimeter. The duct as such is around 13 millimeter, the duct. Next slide. Next, this is a PA pressure. Okay. So here we have a case of 35-year-old lady with a large PDA, measuring around 13 to 14 millimeter with a isosystemic PA pressure, with a relatively normal upper limb and lower limb saturation. Echocardiographically, it is predominantly left to right shunt with a dilated left atrium and left ventricle compared to the right-sided chambers with a severe pulmonary arterial hypertension which is systemic. Yeah.
So Jairannath, let us
go to the cath data.
Before you go on to the cath data, how much did it measure on echo? You said
13 to 14.
13 millimeters.
13 to 14. Okay. And no gradient across the ductus.
Yeah.
Okay.
Can you show that cath data once again?
Absolutely no gradient. It's a pure laminar flow.
Okay. So let's look at the cath data.
Pardon?
Cath data.
Yeah, we'll come to the CAT data.
Cath data, okay. Present the cath data. We did an oximetry because we had a long time here for last 45 minutes to 1 hour. This is the pre-oxygen and post-oxygen cath data. You could see the saturation. There is a clear-cut step up at the PA level. Pre-oxygen and post-oxygen both. Both the descending and ascending aortic saturation is same 95 plus. Aorta and PA are near isosystemic. There is a very minimal drop after the oxygen administration. QPAQ is 3.2 pre-oxygen, 4.3 post-oxygen. PVR is 6.48 and it dropped to 3.8. Anything more, Bharat?
Just wanted to know your views on balloon occlusion.
Yeah. Any comments from the panel? Yeah.
What is the baseline saturation?
Yes. Yeah, I mean, here I think we have a case. Baseline saturation, clinically it was saturation around 97%. There is no desaturation at the lower limb level.
Jaya Ranganath, it's very clearly, clinically it is showing that operable as evidenced by cardiomegaly as well as the ECG showing a biventricular pattern. Yes. Just want to know from point of view, do you actually dependent on QP by QS or in this scenario balloon occlusion? Because obviously later there's a lot of fallacy on oximetry here, whether you are
definitely I don't,
I can actually ask a chairperson to just give a point.
Nageshwar Rao, I completely agree with you. I don't.
Go ahead, Jaya Rangnath.
I don't rely on this QP by QS in a large duct, even if it is still operable. I would go more in favor of the balloon occlusion or the occlude with a device and go ahead. We have done the angiography. Shall I show the angiogram?
Yes, please.
Yeah. This is the aortogram in the lateral view. you could see a large duct, wide ampulla, is a marker pictile there. Next. This is the RAO projection, very large PA with a large duct with quite a good wide ampulla. Next. Here we are measuring around the 12.5 millimeter the duct at the ampulla level 24 millimeter. In the lateral projection, it's more or less same, 13, and ampulla is around 21 to 22.
So you are going ahead with a balloon occlusion?
So this is where we are now. Yes, yes. See, I have put a 12F sheath. Go to the lateral projection. This is a 12F Cook-Mullin sheath with a amplified extra stiff wire. I am passing a static balloon.
Could you tell us what balloon would you use?
It's a static sizing balloon.
It's a Meditech
balloon, which Dr. Bharat uses very frequently.
Medtech sizing
Because
balloon.
I think it is one of the
We don't
balloons
get
which
these
can be
balloons very often,
stabilized.
but
Yes,
now I think one
easily.
was lying down. Medtech, yes.
Yeah.
No, here.
Yes, exactly.
No, I
I mean,
have a
fortunately,
question
Dr.
here.
Bharat, I think I had in our cath lab, we could get it.
No, Jai Rangnath and Dr. Bharadali, here, see, when you are doing sizing, we want to know two things. Number one is we are occluding and then checking the pressure, hemodynamic response. Second, if you want to size the duct, reason for sizing, large ductus arteriosus is never circular. It may be spherical or it may be serpiginous also. So whatever measurement you are taking angiographically, echocardiogram, actually you yourself think that we oversize a bit more in large ducts, especially in this, maybe 4 to 6 millimeter. So I think sizing balloon, not only it gives you the pressure hemodynamic assessment for after 5 to 8 minutes, and also sizing also needed. Medtech balloon, I think sizing is going to be a bit difficult.
I mean, we have never used balloons for sizing, to tell you the truth. We have gone strictly by either echo or angio, depending upon if you have good images. You won't be making too much of error, believe me. You won't be making, and for a patient of this size, even if you go up 4 millimeters or 5 millimeters, would not make too much of a difference on either side, aorta or pulmonary artery. What do you think, Shiva?
The difference between a sizing balloon and these occlusion balloons, these are spherical, whereas that other one is more cylindrical. With a large flow from the aorta into the pulmonary artery, it will be difficult to position a softer, compliant sizing balloon in the ductal position. It will get milked out on the third or fourth cardiac cycle into the pulmonary artery. However, if it is an occlusion balloon, even if it gets pushed into the pulmonary artery, you can push back it against the ductus and still go and occlude it.
Absolutely.
But all said and done, if you are going to occlude the mouth of the left pulmonary artery and transiently create a proximal PA hypertension, again this technique is fallacious. I would go ahead with a device occlusion, direct device occlusion.
You would, I'll tell you one thing. Once you go across the pulmonary valve, you will be causing a lot of pulmonary regurgitation. So the mean pressures will become meaningless. You will go mainly by systolic pressures. The thing is that most of the times, if you make an angiogram with the balloon in position, you will confirm that no flow is coming across the ductus. The second thing is you make an angiogram in the pulmonary artery. It's very rare that the pulmonary artery, main pulmonary artery will get occluded. And if main pulmonary artery does not get occluded, it will not affect the systolic pressure because the blood will follow the path of fluid dynamics, will go in the path of least resistance without. So there will be redistribution of blood, but there won't be change in pressures. Even if it occludes the left pulmonary artery, it will not put up the pressures in the right pulmonary artery to that, or main pulmonary artery to that extent. There will be more flow going on to the right pulmonary artery. I'm not sure what would happen.
Okay. Yeah.
But with these spherical balloons, I don't think the left pulmonary artery is going to get occluded in an isolated way.
I don't think it gets occluded to any significant
No,
extent.
even if you pull it very near the PDA, in the pulmonary end, unlikely that it will, isolated LP stenosis is unlikely probably.
I don't know. I don't think that.
No, in fact, I think there is some data to support Dr. Bharat's point.
The patent ductus arteriosus is a vascular structure, It's a tubular structure. Adjacent to another tubular structure, the left pulmonary artery, a distension of the vascular compliant ductus arteriosus by a large occlusion balloon is going to indent the
Compromise.
walls of the left pulmonary artery.
Compromise.
As Dr. Bharat said, if you go and transiently occlude one of the pulmonary arteries, the blood gets redistributed in the other pulmonary artery. We are talking about a situation where the vascular resistance is not at the level of ostium by the balloons. It is at the distal arteriolar level by the pulmonary vascular resistance. And so here, every small occlusion matters. That is one of the reasons why a branch pulmonary artery banding or a main pulmonary artery banding is never tolerated by a hypertensive child. You have a pulmonary hypertension with vascular resistance, they
can
don't
I,
tolerate.
Okay,
Can I
yes,
interrupt
Jai
you?
Rangnath, we were discussing, now show us what is happening.
Let's see the hemodynamics.
Can I? Yeah. I'm sorry, I had to interrupt you because this lady is on the table for a long time. I've inflated with a balloon.
And it looks great.
And, show the hemodynamics.
Show the hemodynamic on the other side.
Yeah. So
PA
you could
pressure
see that
actually
the PA
dropped.
pressure has dropped to 70, 75.
Which will be great for this
Yeah,
patient.
it has dropped. No, I'm not in actually favor of this balloon occlusion and all. If I'm pretty sure that it is operable, I would go with the device and put it.
And you can always check the pressures when the device is in place, which is a
So all
better
of
way
you
to
agree now
occlude.
this is an operable PDA? Yeah. Okay.
Okay, so we have decided that we will go ahead and close the ductus.
Yeah. I'm going to remove the balloon, putting the sheath back.
Choice of the device, and both in terms of what size and what type.
Choice of the device.
Push the balloon. Push the balloon in. Yeah.
Deflect.
Yeah, I'm just doing that. It's taking time.
No, it's one more.
One more second.
One more second.
I think cameras can switch on. to-
Jai Rangnath, we are asking you what is the choice of the device, size of the device and the type of the device.
I think it's just
Yeah,
deflated the balloon.
No, type I think I would go because there is a clear cut drop in the PA pressure more than 30 to 40%.
Correct.
I would use a duct occluder, standard duct occluder, PDA occluder. Okay.
And what would be the size?
Size, I think I decided to use probably, what do you think? What is the audience?
So your
Size.
measurement is 12 to
This is a old
13
balloon, I had some
millimeters
difficulty
by
in
echo
this one.
and
Yeah.
two angiographic views.
13 to 14 millimeter, Nagesh.
So
Jai Shivakumar, I would go for a 22-20 or a 24-22 ADO1.
Yeah.
So anything more than 18
Yeah, mentally I
millimeter,
think I had made
minimum
up
4 to 6
Shiva
millimeters.
24, 22. What do you think?
minimum is 2018 and anything above that, but
Yeah.
2018 should be good enough. But even 20 to 20,
Yeah.
I don't think that I have any severe objection to
2018 you
that
think?
in a lady of this size. Anybody in the audience has
What's
any
this
different
thing?
thoughts?
20,
Vishwajit?
22 by 20 should be fine.
Should be good enough. So everybody believes with your hemodynamic data that we can go ahead with ADO1 and that the size should be anything either 20 by 18 or above.
As Dr. Jai Rangnath is getting ready the device, let me add a small
I would probably go for a 22.
a small word of caution about this truly
Yeah,
hypertensive
Shiva. Yeah,
ducts.
yes, Shiva, go ahead.
In these, some of these patients where we have implanted these
Yeah.
20, 22 devices and all, at the end of 1 to 2 years, we have recatheterized them. And the pulmonary artery pressures are more or less around 80% of systemic. And they continue to need dual pulmonary vasodilators at the end of 1 to 2 years. So this is a disease which we need to understand that we are doing a partial job and we need to totally depend on continuous use of pharmacological agents, maybe for the rest of the life of this patient. Because at the end of 2 years, also, I have not found a reduction of the PA pressure when we did an invasive catheter hemodynamics on these patients whom we have put in the 22, 24, 24, 26 and all. So
As a matter
I
of fact,
totally.
I mean, I'm sure that this patient will come down immediately.
will
I'm
not
not-
come
I'm
down
not
to a
worried.
great
You-
extent. Will continue to remain around 75% of PA systolic for a long
No, I
period. of
agree with Shivakumar. I have few patients like not only for PDA, even if for a VSD, if you close at an older age, then there is a problem. I mean, persistent pulmonary hypertension does remain in
I
lot of
remember
patients.
5 years ago, I was giving lectures vouching for this balloon occlusion and device occlusion as a very noble method of assessing the operability. Today, I say it is just one method which has got some logic, but it is not acceptable.
Shivakumar, we are not only going by this. You look at the clinical picture, look at the X-ray, look at the ECG, look at the hemodynamics, and then putting all this data together, I have no doubts that this patient's pulmonary artery pressure will drop to below 50% at the end of 1 year. I don't think this is one of the candidates who will require long-term pulmonary vasodilators. I may be wrong, but this is my feeling looking at the data. And we will be presenting, as a matter of fact, our article will appear in this issue of Annals of
Can
Pediatric
we
Cardiology.
just, Jai Ranganath, what are the sheath and device? Just tell the hardware to others.
Show the hemodynamics. A 12F sheath, Mullin sheath, because I had to use the 12F, there's no need of using a 12F sheath actually, but I had to put up that balloon, so I had to use a 12F sheath, Mullin sheath. See the hemodynamics now. This device is 22 by 20 ADO, that's a LifeTech device, a PDA occluder.
Yeah.
Size of the sheath, size of the
PA
delivery
pressures
sheath.
are
Hemodynamics
lesser
now,
than
we are showing
50%.
You could see, yeah,
It's just 50%, PA pressures are 50%.
yeah.
Systemic pressure has gone up.
So this PDA was clearly operable. So we'll do some injection now, angiogram. Okay.
What is the size of the sheath you told?
12 French.
Coming to the RO.
Arrivo. 12F sheet.
12 French sheath.
12F cooks.
Jai Ranganath, it looks good, but do you think that after having positioned the device, a little bit more flaring, you would have been happier? Which means another 2 millimeter more?
Yeah.
Because the fear here will be
I think
not
I was
having a
planning to put
larger
a 24
pulmonary artery
Shiva
disc
actually.
to prevent a reverse
Yeah,
embolization
yeah.
from the PA into the aorta. And if you are using
Correct,
an
correct,
ADO1,
correct.
the larger and larger the flaring, it will be good for us.
Yeah.
It's very common to undersize the
Correct, I agree with you,
device
Shiva.
when you have a large ductus arteriosus. I think unlike atrial septal defect and VST, a ductus arteriosus device, ADO1 should be at least 4 millimeter higher than what the defect, especially when you are dealing with a large PDAs.
I would be even more liberal,
Hypertensive.
6 to 8 millimeter larger.
It's a minimum should be 4, not the 2 millimeters and all. Several times we see that a device will come out and there will be residual leak and you don't have central constriction. If you
we have
don't have
improved several
central
millimeters
constriction,
here.
the PA pressures are very high actually. There will be, you are doing the procedure under anesthesia, there is always a fall in PA pressure. Once the patient gets up, and if there is a catecholamic surgery, then PA crisis may go up, PA pressure may go up, and there will be potential danger for the embolization. So these particular situations, either safer to use either muscular VST device or oversizing the PDA device. How oversize means usually we oversize by 6 millimeters. Here I think Jai Ranganath oversize is almost like what the 14 millimeters to 22 millimeters.
8 millimeter.
So Jai Ranganath, what the
Yeah,
hemodynamics now?
28 millimeter oversized. I am pretty okay with this. Yeah. Yeah. Hemodynamics is PA pressure around 52. Systemic PA pressure around, I'll connect to
Systemic
the
was around 130.
It's not that the PA pressures
This is the
are going to
hemodynamics,
be like that
Nagesh.
forever. They will have continuous high pulmonary vascular resistance for some time. So it's mandatory to give pulmonary vasodilators. And do you have echocardiogram
So what
there?
shall I release it now? Are you happy?
I take this out.
Jai Ranganath, are you doing echocardiogram? This is very important.
Yeah,
when you
I have
close
echo.
the left to right
Yeah.
hand, there will be acute left ventricular dysfunction.
Yeah.
Quite
And
often we see
aortic
in,
regurgitation
children.
also.
Yeah, I
Aortic
completely agree with you,
regurgitation,
Nagesh. I have seen quite often that. I can show you the echocardiogram now.
Yes. We want to see the ventricular function.
Echo.
It's quite transient most of the times, but it's very important, especially small babies
show the
and all.
echo.
Sometimes we need to give inotropes. It's taking off like acute preload
So
to the
this is
left
the fourth chamber
ventricle.
view. Nageshwara, are you
Yeah.
seeing the echo?
Yeah, we can see the echocardiogram, apical four-chamber view.
What is being discussed in this last 1 or 2 minutes is a transient left ventricular systolic dysfunction that happens after closure of a large patent ductus arteriosus. In patients who are having a low pulmonary vascular resistance and high systemic vascular resistance, there is a large runoff of blood from the aorta to PA. And so an acute closure of the ductus is going to raise the systemic vascular resistance further, resulting in a ventricular dysfunction. If the patient is a very borderline patient who is having already a high pulmonary vascular resistance, that may not produce a left ventricular systolic dysfunction. Because in this, the runoff is not too much.
Shiva, I am releasing it now.
Yeah.
Yeah. There's one paper actually published by Omar Galal from Saudi Arabia. One of the explanation is you are taking out acute preload, like a mitral regurgitation, a chronic mitral regurgitation you operate, underestimated LV function.
Afterload mismatch.
Afterload mismatch, they develop ventricular dysfunction. So you see transiently that kind of phenomenon. It's very important to notice that. It looks very good there.
It's beautiful.
It looks very good, Jay.
I think the message.
Nageshwara, Shiva,
message
we have released it. The PA pressure is, yeah.
PA pressure now, yeah, I can just give the, it remains the same.
Shiva, what do you do
Pressure monitor?
if there is an embolization next day, these kind of cases? Because Majni LV group, they have done large PDAs, high pulmonary vascular resistance group. They keep the cable without deploying the device overnight.
Diaphragm?
Keep the patient in ICU
Fluoroscreen,
ventilated and then check the hemodynamics and all. I think you are aware of the.
They were talking about it 6 years ago, no longer nowadays. But yeah, true. At some time ago they were.
Already thrombosis at the, so much it is closed down. Yeah, it's beautiful. I think all out, I can leave it.
There is no
Any more,
flow. There is
thing
no
you
flow of
want,
contrast
Shiva,
even through the
Nageshwara,
fabric.
Bharat?
yeah.
Yeah.
I think already there's a lot of clot formation.
It looks like a pre-clotted device.
Don't even see a.
Dr. Ziad, about some close to 10 years before, used to talk about taking the device,
that
soaking
takes,
in the patient's
Shiva?
blood for about 20 minutes and then deploying it to avoid a residual flow through the fabric of the device. But if you see, he has used a LifeTech device. The LifeTech device inner fabric is PTFE. It's like the Gore-Tex membrane. And so, while many other devices may have polyester as their fabric, the larger LifeTech devices uses PTFE, and so I think it's more quickly
So
absorbed.
now commercially available Senjut Amplatjet devices, maximum is coming 2022. Whereas the LifeTech, I think they custom made up to 26.
28, 30.
28, 30. We use maximum device of 24, 22.
I have like 3 patients, and when these very large ductus devices were not available, I used ASD device in those patients because nothing else was available in the lab. But these 2 of them did very well, and one patient had really bad hemolysis. But then after about a week to 10 days with conservative management, it settled. So when you have, now we have all these big devices, big PDA devices, but previously when we didn't have, even now up to 28 is available, right?
30, up to 28, 30.
30 by 28.
I think some people use AST devices. The major disadvantages of AST devices are short length of the wrist, and it is actually designed for the low flow situation, low pressure situation. You are dealing with a high pressure situation. So even if you position the device very nicely, there will be intra-device shunt is quite common, and there are case reports noticed that a hemolysis and residual shunt through the AST. I don't think at this moment we should be using AST devices for the PDA location unless it's a bailout situation somewhere else.
The anatomy of ductus arteriosus is often tubular. If it is like a strict window, then probably there may be a role for a ASD device.
So, Jai Ranganath, what's happening? We would like to know what the...
Waiting for the hemostasis. Very good
So
job, Jai.
everything is finished. We are through. You were discussing. We were.
So,
hearing
would you
everything.
like to catheterize this
Yeah, I mean,
patient
thanks,
after
Shiva.
3 to 6 months?
Thanks once again for. Yeah. No, I see. I mean, Nageshwara, I think I have had probably last 3-4 years about 8 to 10 similar ductus I have closed. I think the PA pressure will drop by 6 months to 1 year in most of the cases. The LV function has gone down initially in couple of cases. They were all improved. 1 or 2 cases we are kept in the ICU, given some inotropes. As you said, the LV dysfunction will set in. But I think I don't need to cath because we're pretty sure that the PA pressure has dropped significantly. This is one case where clearly it was operable by hemodynamic methods. I don't think we need to cath clearly unless there is a clinical indication. I think that's it because we follow up with the echocardiogram. As you said that we'll keep these people on the vasodilators, sildenafil or bosentan. We keep a follow up regularly.
Yeah.
That's what it is.
I think these kind of case scenarios is still common in our country. Elderly patients with large ductus arteriosus is still operable situations. Yeah. But we don't know the long-term follow-up of these patients, whether pulmonary vascular disease will progress or will stop at that particular time. I think it's important to give the pulmonary vasodilators. We congratulate the team from Jaya Deva, Dr. Jai Ranganath and his colleagues there for doing a great case and good hemodynamic demonstration. We thank Dr. Jai Ranganath and your colleagues over there. Thank you very much.
Thank you, Dr. Nagesh. Thanks once again. Here with me, this is Sunday. Let me thank my anesthetist team, Dr. Srinivas, our cath lab team, our nursing staff. Thank you once again for giving us this opportunity, Dr. Nagesh.